Welcome to this lecture. As you've heard, the continuous suppression of allograft rejection is key to allograft function. Downside of this immunosuppression is the lifelong increased risk of infection and cancer, as discussed in the introductory lectures. In this lecture, we will focus on infections after transplantation. After viewing this lecture, you will be able to understand why specific type of infections occur almost like clockwork at specific times after transplantation. Besides that, you will know the clinical presentation and diagnosis, treatment and prevention of the main opportunistic infections. Let's start with the changes in host defense after transplantation. After transplantation, we can distinguish three different types of impaired host defense. First, the disruption of anatomical barriers, secondary to the surgical wound and the implantation of the renal transplant. This is followed by a period of intense suppression of cellular and humoral immune responses from the second month up to 1 year after transplantation. After that, the final stage of chronic immune suppression ensues. Next, we will discuss which type of infection occurs at each stage. Let's first start with the disruption of anatomical barriers, such as surgical wounds, indwelling urethral stents, and urethral catheters. This may result in bacterial infections with skin or gut bacteria. These bacterial infections occur in the first days or weeks after transplantation. Perioperative prophylactic antibiotics directed against skin and gut bacteria are used to reduce the risk of these infections. Sometimes a donor has acquired a bacterial renal infection in the days before explantation. And with the emergence of multi-drug antimicrobial resistance, routine prophylaxis may fail to prevent these types of infection. Rapid communication of complete microbiological susceptibility data by the Organ Procurement Organization is essential to guide treatment. So remember that disruption of anatomical barriers can lead to bacterial infections with skin or gut bacteria during the first weeks after transplantation. During the second stage of intense immune suppression, the immune control of chronic viral infections, both present in donor kidney and in the organ recipients, is weakened. As a result, latent viral infections may reactivate. Examples are viruses such as Cytomegalovirus or CMV, BK virus, and Epstein-Barr virus. In the first part of this lecture, we will discuss CMV infections in more detail. In the second part, we will focus on BK and Epstein-Barr virus. The stage of chronic immune suppression will be described in the optional reading. We will first discuss CMV infection for two reasons. First, it's the single most important infection in transplant patients, and secondly, it can be used as a model to understand other opportunistic viral infections. Like all herpes viruses, primary infection with CMV results in lifelong latency. As with many infections, the chance that you have acquired CMV increases with age. In transplantation, CMV is most commonly transmitted by the latently infected organ from a seropositive donor. Clinical disease is most likely to develop in seronegative recipients, as is shown in this table. Clinical disease is also more likely to develop in seropositive recipients from seropositive donors. This is because there is considerable antigenic heterogeneity between different CMV strains. As you can see, the risk increases when the recipient has been treated with anti-thymocyte globulin. Injury, be it through ischemia, inflammation or infection, can act as a trigger for reactivation of CMV from latency. On the cellular level, this translates to any process leading to the release of the inflammatory cytokine TNF. So what are the consequences of CMV reactivation? Replicating CMV causes a viral vasculitis. The typical intranuclear inclusions of CMV have the appearance of owl's eyes. CMV affects the transplanted organ far more frequently. Possibly because of the MH-class mismatch between donor and recipient, virus-specific cytotoxic T cells are less able to eliminate virally infected cells. What are the clinical manifestations of CMV disease? Well, clinical disease is characterized by unexplained fever, respiratory symptoms, and bilateral, symmetrical, peribronchovascular, interstitial, and alveolar infiltrates on the chest X-ray, starting about 4 weeks after infection or injury. The gastrointestinal tract is also a major target for CMV disease. In contrast to the former, gastrointestinal CMV disease is often not accompanied with CMV DNA in the blood. CMV causes downregulation of MHC class I antigens, which contributes to the immunosuppressive effect of CMV infection. This leads to an increased risk of superinfection with opportunistic pathogens, such as Pneumocystis jirovecii, which will be discussed in the assignment, or the increased risk of EBV-related post-transplantation lymphoproliferative disease, which will be discussed in the following lecture. So how can we prevent this from happening? There are currently 2 strategies to prevent CMV disease with antiviral therapy. First, universal prophylactic treatment of all recipients from 3 to 6 months, depending on the risk. Secondly, preemptive treatment as soon as a certain asymptomatic viral replication threshold determined by polymerase chain reaction or PCR is reached. The main disadvantage of the first strategy is the occurrence of CMV disease shortly after stopping antiviral prophylaxis. The second strategy may carry a higher risk of acute rejection because of the CMV-induced vascular allograft injury. Immune monitoring of CMV-specific T-cell responses look promising as a tool to predict the risk of CMV disease after transplantation or to help decide when to stop prophylaxis. There are different antiviral drugs against CMV. Valganciclovir is a prodrug. After oral administration, valganciclovir is metabolized to the active parent drug, ganciclovir. In patients with non-life-threatening CMV disease, treatment with valganciclovir is the preferred choice. In severe CMV disease, treatment with intravenous ganciclovir is required. Treatment should be continued until CMV replication is no longer detectable, with a minimum duration of 2 weeks. So, what have we learned so far? We have seen that 3 different stages of impaired host defense can be distinguished after transplantation. Each period has its specific type of infection. During the phase of intense immune suppression, the immune control of chronic viral infections weakens, leading to new infections or reactivation of viruses present in the donor kidney or in the organ recipient. CMV is the most important infection in transplant patients. So, how can we apply this knowledge when we study other viral infections like BK virus or EBV? This will be discussed in the second part of this lecture.